As rising nurses practicing in the clinical setting, a discrepancy regarding nutrition, specifically the lack of emphasis on protein intake, has been greatly identified across multiple hospital settings. We have observed meal trays at the patient's bedside without any meal setup or eating assistance, which has an impact on the amount of meal consumption. While patients are strongly encouraged to adhere to medication compliance, deep vein thrombosis prophylaxis, becoming independent, remaining active by working with physical therapy and occupational therapy, and so forth, little patient teaching has been done on the importance of increased protein intake during their hospital stay in order to promote healing. We found a research article called Clinical Outcomes of Inadequate Calorie Delivery in Protein Deficit in Surgical ICU Patients by Dante Ye, which found that patients with a cumulative protein deficit of 300 grams or greater were 1.5 times more likely to experience complications during their hospital stay. Increased consumption of protein is similar to medication compliance, in that it should become a part of the patient's lifestyle and work with all aspects of care in order to reduce hospital stays and further medical complications. After identifying this problem in the clinical setting, we came up with our PICO question, which is, in patients with chronic illnesses who are hospitalized for a minimum of 3 days, does an individual sitter who provides eating assistance during meals, as opposed to no individual sitter provided, increase the percentage of protein consumed? Our P, which is our population, are chronically ill adults in the hospital setting. Our I, which is our intervention, is an individual sitter who provides eating assistance during meals. Our C is our comparison, which are patients without a sitter to provide the eating assistance. Our outcome, which is our O, is the higher percentage of protein consumed measured in grams. And our T, which is our timing, which would be during a hospital stay of a minimum of 3 days.
Basically, this is what we found from the search criteria. Number one, we went to Galileo and we went to Senegal and typed in a search term as nutrition, hospitalization, patients, and stress. So we yielded 34,425 articles. So this was too much. We went above and added adults and nursing in the search terms, and we got 6,162 articles. This was too much. We added a limit for English and within 5 years. So we got 2,177 articles. This was again too much. We went and added above improved outcome and reduced complication. We got 1,466 articles. This was too much. We added in the limits peer reviewed, and we got 24 articles, and from those, that's where we chose from. In the second search criteria, we went to Galileo and then went to Psych Info and put in meals and social as a search term, and we got 2,014 articles. This was too much. We went and put in the search in the limit peer reviewed and got 1,524 articles. This was again too much. We went and put above 2011 and 2016 in the search limit. We got 730 articles. This was again too much. We went up and added nursing in the search terms. We got 44 articles. This was too much. We went up again and added eating to the search term. And then in the search limit, we added above and peer reviewed, and we got 6 articles. This is what we chose from. In the third search criteria, we went to Senegal and put in a search term as social and eating, and we got 3,000 articles. This was too much. We went and added in a search limit for academic journals 2012 and 2016, which were full text, This gave us 900 articles. This was again too much, and we added nursing to the searching term and got 52 articles. From 52, that's what we chose from. In the fourth search criteria, we went and put in a search term as nutrition and nursing. So the search limit was full text, and we got 259,000 articles. This was too much. We went to the search limit and added 2011 to 2016. This gave us 102,000 articles. This was again too much. We went to PsycInfo database of articles and added academic journal and peer reviewed to the search limit. This gave us 97,000 articles, and that's what we chose from. In the fifth search criteria, we went to Galileo and then went to Cinehall database of articles. So from that, we went to the search term and put in nutrition, intervention, and chronic diseases. In the search limit, we put academic journals and from 2011 to 2016, which were full text and peer reviewed. This gave us 117,000 articles. This was too much. We went and put in search term, another search term for hospital setting or acute setting. So this gave us 97,000 articles. This was again too much. We went in the search terms and added nursing interventions. This gave us 30,000 articles, and that's what from those, that's where we chose from.
When we conducted our literature review, we found that there was little research supporting having sitters at mealtimes in hospitals, but we came across a lot of research that supported our PICO question. We know in hospitals that sitters are used routinely for patients who are combative or uncooperative, but there are little or to no sitters included during mealtimes, specifically for mealtime assistance. The research we came across focused on several aspects of mealtime during hospital or nursing home stay. These research articles included information on the holistic nature of eating, mealtime setup, meal evaluation for dementia and elderly patients, and nutritional outcomes of hospital stays. It was from this evidence that we could pull information to support our PICO question. We found a research article from Walton in 2012, and it focused on the holistic nature of mealtime. It discusses providing assistance at mealtime and providing tools to help patients with mealtimes, like providing choices, providing serving size, help with serving size, and protecting the mealtime. It discusses the need to integrate teams to provide and improve nutritional outcomes. The idea of providing a sitter at mealtime is a way that a mealtime can be protected and be maintained. This supports our PICO question of having a mealtime sitter. Also, Young's 2012 study supported our PICO question, and it was related to food assistance. Young's research stated that sitting up while eating and having someone help with feeding increases food intake.
If we were to have someone in the room to help while eating, assistance with feeding could be attained throughout the meal. This study also stated that malnutrition and nutritional defects can lead to a longer hospital stay. It is the goal of our PICO question to increase protein intake and thus reduce the length of the hospital stay. This directly supports our PICO question. If we can get patients to have a higher nutritional intake, their hospital stays would be shorter. Greater social support during mealtime would result in a higher nutritional intake and a shorter hospital stay. Many of the patients we came across in the studies, studied the effect of nutrition and eating with dementia in elderly patients. We believe this information can be generalized to the population of our PICO question. Many dementia patients' eating abilities need to be assessed. Also, according to Dubé's 2012 research study, it stated that the amount of time spent during the provider-patient socialization at mealtime influenced the amount of the meal eaten. The social aspect of eating was also the subject of studies. One study by Sarah Barnes evaluated pre-plated meals with family-style meals, and in this study, it proved that family-style meals had better outcomes with body weight and motor function. This can be applied to our PICO question because family-style meals involve a more social atmosphere and is not done in a solitary setting. A meal sitter would provide the social link that's missing in mealtimes in hospitals. This is often overlooked and not valued in the hospital setting.
This is our critical appraisal of the study by Young called Assisted and Protected Mealtimes, exploring the impact of hospital mealtime practices on meal intake. This was an observational study published in the Journal of Advanced Nursing, which is a peer-reviewed journal published each month. The aims of the study included observing mealtime practices and measuring meal intake. To do this, 601 meals were observed across the floors, and practices like positioning, assistance, and interruptions were noted. Meal intake was then assessed. Instructors were given some basic instruction on how to assess meal intake that was consumed, and a local audit tool was used to measure. But this local audit tool, the reliability and validity was not assessed. Lots of bias could have been in this study based on objective observation, an uncontrolled environment, and difference in patients' food preferences and health, and these could have been seen as extraneous variables. In this study, there was no intervention given. Simple observations were made, and then meal intake was measured. So there was no assignment to group based on the intervention. The sample size was large, but no power analysis was done to determine the appropriate sample size for this study. There's not much information on what other studies have found regarding the mealtime practices. They did, however, observe that mealtime interruptions had no effect on the mealtime consumption, which was what was previously thought. The findings showed that 40% of patients ate less than 50% of their meal. 67% of patients sitting up ate greater or equal to 75% of their meal, while only 46% of patients who were lying down ate greater or equal to 75% of their meal. 82% of patients required some type of setup assistance, and only 18 required assistance with the actual feeding. A smaller number of patients were interrupted while eating, and there may not be enough data to make an assumption about how mealtime interruptions affects mealtime consumption. The study included patients from various floors and can be applied to the general population because of that. More research is definitely needed on this subject because while difference in mealtime consumption did show an increase in certain practices, it is not a large amount and cannot be conclusive. This study does not have a high credibility level. There were multiple chances for extraneous variables to change the results of the observations and outcomes of the study. No standard intervention was measured, and no measuring tool was used that was reliable and valid, and a lot of the observations were objective and could be different based on the person observing. So no accurate cause and effect statement can be made about this relationship based on just this study. In our opinion, this study does have clinical significance. It shows an association between sitting up and meal intake and with meal assistance and meal intake. So this study can be generalized to all hospitalized patients based on the diversity of the meals that were observed. In the clinical setting, nurses can use this information to help their patients with mealtime intake. So improving nutrition can decrease heal time and length of hospital stay, resulting in better health outcomes not only for the patient, but it financially benefits the hospital by decreasing food waste and by decreasing the length of hospital stay.
Our research showed us that protein helps to increase patients' healing. And so our main goal with our evidence-based project would be to increase a patient's consumption of protein during their normal meal time. So our theory is that increased protein consumption will improve healing. As a method to increase protein consumption, the patient should have the appropriate assistance during the meal time. The assistance is key in the patient being able to consume more protein and adequately consume the whole amount of their meal, but specifically the protein is what we would be looking at. So our hypothesis is if mealtime assistance is provided to patients, then the amount of protein consumed each meal will increase. So the projected sample, the sample that we're looking at, is patients that are admitted to a hospital for 3 or more days. Half the patients on the floor would be provided with a mealtime assistance, and the other half would be the control group and not provided the mealtime assistance. Their protein consumption would be compared to each other after it's been measured. So our intervention would be that mealtime assistance, such as arranging the tray, sitting the patient up, or helping to actually feed the patient would be provided by our mealtime assisters. So our outcomes that we would measure would be the grams of protein consumed. So to implement this, each patient would receive a pre-measured amount of protein with their meal. After the meal, the protein would be weighed in order to determine how much had been consumed and how much was still left on the plate. These weights would then be documented and compared between the interventional and the control groups to show which patients consumed more, the ones that did not have the assistance or the patients that did have the mealtime assistance.
From our research, we found little information on our specific PICO question. We did find more basic information on the principles of increased nutrition as it relates to healing time. We wanted to take that a step further and see how we could apply that to our hospitalized patients. Ensuring adequate nutrition should be a part of normal protocol in the hospital in the same category as DVT prophylaxis and medication adherence. It's that important for patients' health and decreased hospital stay. So our PICO wanted to look at how we could increase patient protein intake, and since we've all helped feed patients in the hospital before, that's where we started. Other studies identified things like sitting up at mealtime, family-style meal, socialization, and then things like giving different options regarding the food and the menu as a way to increase consumption. We wanted to focus on the actual physical assistance of the patient in our PICO question. This leads to our evidence-based practice protocol, which calls for specific interventions with eating assistance, which will be compared to groups who don't receive any eating assistance. Our theory is that patients receiving assistance will consume a higher percent of their protein in their meal, which will lead to more adequate nutrition. So there is a need for more research on this topic to figure out the best intervention for the patients as a way to increase their protein intake, and the best way to implement this as a protocol in the hospital, whether that be hiring someone to specifically help patients with mealtime or working with food management to change menus and change the options that patients have. So these are easy interventions that all nurses can do in the future. In the future, there may be a hired personnel in charge of mealtime assistance, but for now, this lies mostly on the nurses. So the best thing that we can do clinically is sit patients up, make sure that they can adequately feed themselves, and if they can't, providing that assistance, and socializing with them during mealtime to make it an enjoyable experience. So this will benefit the patient by increasing their nutrition, increasing healing, and decreasing hospital stay, as well as also financially beneficial for the hospital by decreasing food waste and decreasing length of hospital stay.